All right, hello everybody. I'm Brian. This is AAMI News and Conversation, and we're here at the first full day of AAMI Exchange in New Orleans, 2025. And I'm here with Ralph Basile of the AAMI Foundation. You probably know and love him well. And Karen Haberland, who is a researcher over at ECRI. We're going to be talking about some really cool research today, so I'm excited to dive straight into it. But before that, I do want Karen to give you a chance just to tell us a little bit about who you are and what your work is focused on.
Yeah, thanks for having me. So I'm Karen Haberland. I'm a senior project officer at ECRI. We're an independent nonprofit research institution, and we do a lot of evaluations of any medical device that our member facilities want us to test. And lately I've been doing a lot of testing on disposable isolation gowns. That's what we're talking about today. That's what my talk was of this morning.
Yeah, and I should add, we love our friends at ECRI. Patient safety is a big North Star for AAMI's mission as well. So there's been a lot of cross-pollinating in the past there, leading into standards and things of that nature. So it's really cool to see two new papers that are probably going to feed into that same pipeline, right, Ralph?
Yep,
Yeah.
for sure. Yeah, they'll inform the standards that underwrite protective attire. Yep.
Yeah. So why don't you tell us a little bit about what these papers are? And I should say, for those who are interested in checking them out, we'll put two links in the description. They were both published in BINT, AAMI's peer-reviewed journal, very recently. I think it was on the 16th. So Karen, just elevator pitch me. What was the focus of this work?
Yeah, so ECRI's been doing testing of disposable isolation gowns since the pandemic started, and everyone started saying, these gowns aren't really protecting us in the healthcare facility, and we were getting a lot of reports to our patient safety network about them. So we really wanted to investigate them a little bit more.
And why do you think we got a spin-up of more reports like that? Is it because there were new situations, new changing environments going on because of COVID, or what was going on there?
Definitely a little bit of that. Definitely, transitioning of who manufacturers were for a little bit when trying to get enough product to cover your facility then. Mm-hmm. And then also just realizing, we should think about how protective these things are and really report them and make sure that these are investigated and that we're wearing the best PPE for the job.
Right. More attention on just protection for our healthcare workers in general, since they're so essential. All right, that's cool. Well, now, Ralph, you got to catch Karen's session today.
That's right. Yep.
Unfortunately, I had to miss it. I really wanted to catch it. I apologize. But so I'm going to let you dig into the details here, and I'll
Sure.
riff off you guys if I have questions.
Yeah, sounds good. Well, Karen, maybe just in summary, and you spoke so well about it from the survey, you identified a number of areas, I'm going to say, of failure. And maybe you could highlight those from the survey.
Right. So we did both a survey and laboratory testing. So for the survey, we sent out a national survey to healthcare workers with experience both purchasing and or wearing disposable isolation gowns. And we really wanted to see really what selection practices were and then what the healthcare worker experience is. So we really found that from the purchasing side, while there are 4 levels of isolation gowns available, which have varying levels of protectiveness, and you really should be choosing those based on the exposure risk of the procedure that you're going into, really we're seeing that it's usually about 1 level that's actually stocked predominantly in certain areas of the floors, and therefore there's not a good chance for the healthcare worker to choose based on the exposure risk of what they're walking into. Mm-hmm. And then we're also seeing that the healthcare worker isn't actually fully trained. About a little over half said that they aren't fully trained on those disposable or those isolation gown levels of protectiveness. They're also not evaluated for competency of wearing.
And for clarification, when they say trained, are we talking about either ways to put it on or what it's suited for?
Both.
Okay.
So really, you'd want to know Both. So for proper PPE protection, you want to make sure that it is donned and doffed properly to lower your exposure risk. So mainly for that is actually closing the back of your isolation gown, because it is supposed to provide 360-degree protection. But if you don't tie it in the back, it's not doing that.
Interesting.
And doffing is such
And
a
doffing.
point of failure, right?
Yes,
Yeah.
doffing. We've seen a lot of tearing or just not properly being able to take it off, so you can be exposed. The outside gets dirty, but if you're exposed to the outside, your scrubs are exposed to the outside when you're doffing, then that's also a problem.
Right. And I think you found too that for the most part, healthcare workers maybe aren't even sure which level of gown they would be recommended
Right.
for
So
the procedure they're doing, including some like blood draw, of which
yes, so there are 4 different levels, and so you have level 1, which is very low barrier protection, up to level 4. Level 4 is the only one tested against blood and viral penetration. So levels 1 through 3 are increasing resistance, but they're only tested against water. So if you know you're going into something with viral potential, then you really want to use a level 4. But typically, healthcare workers, the floor staff, are not trained to that, and don't know that maybe they should be, layering or going up to a higher level for certain situations.
right, and of course the study you very much focused in on strike through, and there was a very high, significant percentage of healthcare workers in the survey that reported that they had experienced
Yes.
strike through.
Yeah, so about a third of our respondents did say that they experienced strike-through. Concerningly, some do experience daily or weekly strike-through. So strike-through is also permeation of liquid through the gown. So that would be a potential exposure incident, because you're getting it on your skin or you're getting it on your scrubs.
Could you describe to me, in one of these instances, if they notice strike through, what are they noticing? Are they did they lean against something and then suddenly their skin is wet through the gown? Is that how that it works? Or?
Yeah, could be. I hear it a lot if you have a wet patient that you're trying to roll or move. It's a lot of times that pressure, putting pressure on the gown. There's also other studies, not ECRI studies, have shown that the glove-gown interface, like the pressure put on the gown by the glove, also makes that area a little more susceptible to leakage.
Oh, that's interesting. So if your gloves get wet and it's tightened around the gown, right? Because the gown is tucked underneath the gloves.
Yeah.
That point of contact is where you're suddenly going to have seepage.
Yeah, or you
Okay.
have wrinkles there or things like that.
Interesting.
Like you said, it's CDC has looked at that, right? Particularly NIOSH,
Yep.
as a significant point of failure, and I don't think it's really still there's opportunities to address that. But the other thing I think that you were sharing from the survey is underreporting of
Yes.
strike through.
Yes. So even though we see that a third of our respondents are having strike through, especially if it's daily, weekly, or even monthly, they're not reporting it. We have 50% never report, and another 26% rarely report these issues to their managers or to their occupational health and safety.
And you dug further. Why do they not report? What were the
Quite a few different reasons, mostly because they didn't know how to report or it was too difficult to report. So we look at that as maybe you should have an easier avenue for reporting to your internal systems or to your patient safety organization about that. Also, we saw that management doesn't care, so we didn't see the point of reporting, which would really speak to ensuring a culture of reporting so that you can investigate these things and make sure that everyone is protected.
For sure. Yeah, even if manufacturers themselves might not know they have a problem on their hands unless people are talking about it.
Exactly. These rarely get reported out to manufacturers. They just don't know how often it's happening and therefore aren't investigating or improving.
Right. And that's really the focus of this research, is improving the test methods for the gowns, right?
Yes.
You talked about it as this is starting an important conversation.
Yes.
Yeah.
Yeah, so maybe we can go to the lab testing that you did. You can talk about that.
Yes, that was a good segue into the lab testing.
Good job.
All right. Hey, thanks.
You get paid to do this?
I think
Okay.
so.
So the second part of our grant study was performing the 2 liquid barrier penetration tests, so impact penetration and hydrostatic pressure, and looking at, do these really reflect the conditions of a healthcare environment? Because they were written in the 1940s. They weren't written for healthcare at all. They were picked up in the mid-90s for healthcare because we realized we really need to be testing gowns.
So what industry did they transfer from? Are we talking about the lab environment or something originally?
It was cotton and rainwear industry.
No kidding.
Yeah.
Oh, that's interesting.
Yeah. So they were kind of the only test methods available at the time, and this is kind of what we stuck with.
Sure.
So they're not necessarily the best equivalent to working in a healthcare environment. The preconditioning is like the humidity is really high in the test method, but really a lot of healthcare facilities, the humidity tends to be really low. Or you're looking at the test liquid is water, and how often are you being exposed to just water in a healthcare environment? And also it's cooler than coming out of a human body.
Oh, sure.
So we redid the tests looking at if we dropped the humidity, or if we warmed the fluid up to body temp, or if we used synthetic urine instead of water. And we redid both of the tests on a couple disposable isolation gowns. And we showed that, in fact, it does have an effect on the outcomes of the test methods. We did see higher strike-through with warmer fluids, which makes sense because it's lower surface tension. So that, to us, means that there would be more fluid going through in a healthcare environment versus in a lab environment.
Sure. I remember when I was first looking through the papers, the photos of the test method setup are actually pretty interesting. You know, it's
They're very simple.
Very simple, but
we
does the job.
we have the apparatus and for both, and it's pretty simple to set yourself up to do that testing. You know, I'm just going to focus in primarily on the hydrostatic testing, because you were talking about the threshold that the method says, and then the reality, which watching the video was dramatic of what happens. And you're talking about 1 versus 2 versus 3 drops.
Yes. Yeah. So the standard endpoint for a level 2 would be that it has to reach 20 centimeters of water before penetration. But it asks for the 3rd point of penetration through the gown. So that kind of piqued our curiosity as healthcare, because, you know, OSHA's not really really allowing that.
Problem, right?
Is like 1 would be a problem, and you might not even see that. So what we did was we actually recorded the pressure at which the 1st, 2nd, and 3rd drops occurred. And we found that in all of the 20 conditions that we did, there were points 1 and or 2 happening before that 20 centimeter cutoff in all but 1 of our test samples. So that means that even though you're recording that 3rd point as you're passing the 20 centimeter cutoff point, you could still have leakage before that, which would not be recorded and is not apparent in the claims of, you know, we reach a level 2.
Interesting.
Yeah, so you're doing your testing. You're not going to fail the gown or the material until you have 3 drops.
Yeah.
If you watch the video, it wasn't drops. It was like literally puddling on the right.
Yes.
And yet you're getting way above the threshold of the amount of liquid getting through, but you're still talking about the 1st drop.
Right. And unfortunately, the standard also does not mention those instances where that 1st or 2nd point of leakage might be more than a drop. And it can be pretty severe sometimes, but there's no discussion of what you should do with those samples. So do you throw those samples out? Do you record that? What do you do? And I've heard a very wide range of what you should do with those samples.
Gotcha. So maybe very thorough discussion and study, and really illuminating for the industry. And so, I mean, I very much congratulate ECRI about taking this on, because we're really talking about the safety of the healthcare worker.
Yeah.
What do you see as the next steps? Where do we go from here?
Next steps I see as really starting the discussion in the industry, because this isn't talked about heavily enough, and really looking at both the guidance for healthcare workers and also the standards, and seeing how we can update them. And that's going to require some more study. So we need healthcare facilities to report these problems. They're not MAUD or MedSun or MedWatch reportable necessarily, but they should be trended internally by your risk management and health and safety, and also report them to your patient safety organization so that we can trend them, and talk to the manufacturers about if you're seeing increases in strikethrough or other issues.
Yeah.
And then also looking at what other ways can we improve the test methods to make them more realistic for healthcare, and that trending of incidents and research into what we can make more realistic will hopefully translate into updating standards and guidance, and make those more realistic.
Yeah. No, that's terrific. And obviously, one of ECRI is that patient safety organization. And, as you said, these may not. They may not be a MAUD event, right? Because there's technically not a failure necessarily, or maybe there's not an event that you can tie to a patient outcome. But ECRI is the organization that can help document that. And the other thing is PB70, the AAMI document, is going to be up again for review and revision. So the timing is very good for that process as well. And then, it's you mentioned level 1, 2, 3, 4.
Yep.
You and I live and breathe this stuff, so we're talking about what's in the AAMI PB70.
Sure, yeah.
Defines 1, 2, 3, 4.
Right,
And
makes
then the
it clear
FDA
words.
recognizes that, as does NIOSH. And then the ASTM methods that you're referring to are test methods to demonstrate meeting the definition of those levels. So we need to up the game on all of those, right? Yeah.
Yep.
Yeah. Well, this is, I mean, it's like you said, it's that important first step for the conversation, but it's also, in the last video we were just recording, we were talking about how the AAMI Foundation is kind of helping feed the right fuel into the engine that is standards development, right? So if we want the car to go further, if we want to really push the industry forward, we need the data. We need that research that is coming out of ECRI and other organizations like it. So thank you, Karen. It's good work. I can't wait to see more. But again, we have the links in the description for both BI&T articles, both the survey and the more extended research.
Yeah, thank you, and thank you for supporting our work.
Great. Thank you.
Fantastic.